Excellent. Number 3, pulmonary embolism. Wow, very good. All right. Keep going. She gets a little prize. Milo. See, that's what happens when you volunteer. All right. So who would? Yeah, type it up. Okay. Who would like to give me the next 3 differential diagnoses? So you can, use the same ones, but 3 other ones. Anyone? Hand up. Anyone? Okay. COPD, yeah. Cardiac failure. Pulmonary edema is caused by cardiac failure, isn't it? So the same one. Can you think of another one? Pneumonia. Yeah. Okay. Can we put them down? All right. Anyone else think of another 3? We've got a very good list of differentials here already. Any more? All right, so far, if you look at the systems, right, we've got respiratory system, we've got cardiovascular system. What other system can be involved that can cause you acute shortness of breath? Sorry? What poisoning? Barbiturate poisoning. Yes, barbiturate poisoning, yeah, a bit on the uncommon side. 53-year-old woman getting access to barbiturates. What else? TB. Yes, TB can do that. Other systems, right? So let's move on from respiratory and cardiovascular. What other systems can cause this? Metabolic, well, yes, metabolic, like what? Acidosis caused by what? Diabetic ketoacidosis, causing sudden onset of shortness of breath. Very uncommon. Possible, but very uncommon. Patient will be almost dying when they get to that level. What about gastroenterology system? Like aspiration? Is that possible? Yeah, if she was eating something and then it went down the wrong way. So it's not really, it's more respiratory, isn't it? Okay, so that's a good list anyway. Alright, let's show the next slide. So, you got, no, let's not show that one yet. Let's go back to the other one. Those are all the answers. Okay, what do you need to ask in the history? Okay, now, you're thinking of those, right? Okay, so, what questions do you need to ask to try to work out which of those, right? The answer is actually one of those, by the way, I'll give you a hint. Okay, it's one of those. So, what questions do you need to ask?
Energy.
When was your answer? Yeah? What? Sorry? What was she doing when it happened? Yeah?
Have any energy?
Like? What kind of pain? You're thinking of what? Pneumothorax? Yeah? What else can cause chest pain and dyspnea at the same time? Cardiac failure? Yeah, good. What else can cause chest pain and dyspnea at the same time besides cardiac failure and pneumothorax? From the list? Pulmonary embolism. Excellent. So, alright, so we can ask about onset, we asked about associated chest pain. Anything else we need to ask about? Allergy? Yes. Sorry? Sorry, I can't. Expiratory or expiratory one?
Dyspnea.
Dyspnea. So, Okay, all right, yeah, you can, yes, that's important. What else?
Do you smoke?
So does the patient have a past history of hypertension is what you meant to say, isn't it? Yes? Yes, that's what you meant to say. Because hypertension, right, is not really a symptom unless it's part of the past history, right? Because hypertension is actually a finding, so it's an examination sign. But yes, you were thinking about past history of hypertension. So yeah, we need to ask about past history. Past history of asthma, smoker, um, heart disease, reflux disease, whatever it is. Okay. Um, all right, next slide. So we show that. Okay, so we're down to the bottom of the slide now. We're talking about past medical history. And then you might need to think about family history or psychosocial history if there's anything else that you're thinking of. Family history is very important. It's always good to actually ask, is there a family history of this condition affecting some other family member? Because that can give you a clue. Okay, next one is, all right, yeah, show that. So this is what the patient gave us. History of the presenting symptom, acute onset 2 hours ago. So all those who asked for onset, very good. Severe, constantly gasping, can't finish a sentence, and this is the first time that it happened. Asthma, yeah. What else? Hyperventilation syndrome, like a panic attack, yeah. Excellent. 53-year-old woman, yeah, that's a risk factor for it. What else? From our original list of differentials, so pulmonary embolism is still there, pneumothorax is still there. Can you actually show that initial slide again? Is there anything from there that you can actually cross out that we can delete? What can we delete? Okay, let's delete that one. Hey, it's not funny. Come on. Alright. Alright, obituary poisoning is gone. Anything else we can eliminate? See, so we're trying to narrow it down now. As we get more information, we narrow it down. So what can we eliminate? You want to eliminate TB? Yeah, I would agree. We can probably eliminate TB. Aspiration? Yeah. Because she's not giving us a history of having eaten something that has gone down the wrong way. Okay. Pneumonia? Yeah, because it only occurred 2 hours ago. Yeah, so it's too sudden for pneumonia. Yes or no? First onset. Yeah, and dyspnea. Yeah. All right. I don't think we can eliminate any more at the moment with the information we have. Okay. So can we fast forward to where we were before? This one. Okay. Associated symptoms. No headache, no nausea, no visual disturbances, no confusion. I don't know why. I don't agree with some of those there, but that's what was given to me, so it's not my fault. All 4 limbs, full motion and sensation. Gosh, why would that be relevant? Anyway, okay, next. So, in other words, there are no other symptoms, okay? Okay, next. Alright, so looking at the past medical history, she said hypertension. So, excellent, see? You're thinking along the right track, even when you weren't quite sure about it, right? Yeah, exactly. Hypertension for 20 years without etiology, defaulted on treatment, so she didn't have any treatment. So untreated hypertension for 20 years, right? Nothing in the family history, she's not on any drugs. Now, does that change your differentials now? All right, let's go back to that list. Okay, so which is our top of the list now? Oh, see. See? Clever. Really clever. Excellent. Okay. No, we don't need to change it. Let's jump back to where we were before. Okay, so, all right, now we're going to move on to examination. Don't show that yet. All right, so now we're thinking, now we haven't even examined the patient yet. So we haven't actually started looking at the patient. We've only been talking to the patient, okay? So now, examination. What do you want to know to help you confirm your provisional diagnosis of cardiac failure? Who said that? We're talking about examinations, we're not talking about investigations yet. Gosh, in your hospital must be very rich, isn't it? Just start throwing tests before they actually even look at the patient. So, physical examination, what do you want to know? Number one. All wrong. What is the first thing you want to know? Is the patient conscious? Yeah. Good. What else? So a general inspection. Yeah. So she's conscious. She's breathing. She's complaining, doctor, you're wasting my time because I cannot breathe and it's been so how long already and you still don't know what's wrong with me. So you're looking at her posture and the degree of respiratory distress that she's in. Okay, so what vital signs, hint, do you need to know? Respiratory rate? Yes.
Heart rate.
Pulse? Yes. Blood pressure? Yeah. You know she's got hypertension. Why don't you want to know her blood pressure? Slowly getting there, is it? Alright, relax. Is that right? Okay. You want to know the blood pressure? Excellent. What else do you want to know? Alright, so you've got the vital signs, and then we go on to examining the cardiovascular system. Right, now remember, when you examine the cardiovascular system, it's a step-by-step process, isn't it? In Australia, we start with the hands, and then we end with auscultation of the chest. So all of you who said auscultation first is wrong. Okay, that should be at the end. Okay, so you start with the hands. Look at clubbing, all that stuff, pulse rate, blood pressure, all that kind of stuff. Get to the chest. Well, before you actually go to the chest, look at the JVP. That's right. And what do you expect the JVP to look like in the patient? To be elevated. That's right. And you expect the blood pressure to be high, you expect the patient to have tachycardia, and you expect the patient to be tachypneic. Right? So you already know what the signs are going to be even before you actually examine the patient, don't you? Correct? Yes. Okay. Okay. All right. So from the neck, then you go down to the chest, and you go through the again step-by-step process. Inspection of the chest, looking at signs of respiratory distress like intercostal recession, look at any sort of chest deformity of the chest wall. You palpate for the apex B. And what do you expect to find about the apex B? It is displaced. Yeah. So I want you guys to start using correct terminology. So when I say, so when I ask questions, try to use correct terminology. Get in the habit of using correct terminology. Because when you're actually working, especially final year students, most of the time you're actually reporting all these things to another doctor over the phone. So you're not actually seeing, so sign language doesn't help, right? And then saying, oh, it's there and it's here and all, it doesn't help. You need to be able to explain it in words and explain it as clearly as possible so that the doctor on the other side of the phone knows exactly what you are trying to say. And you are the eyes and ears of the other doctor on the other side of the phone. Okay? So, apex B, you expect it to be displaced, right? And congestive cardiac failure, you expect the apex B to be besides the space, also you're talking about the quality of the apex beat, like hyperdynamic apex beat, or you could feel a thrill, and then you listen, and you're listening for what?
Murmur.
Murmur, yeah. What else? Sorry? Pathological sounds, yeah. Yeah, so heart murmur, extra heart sound, like a third heart sound, is what they're thinking, right? Right? And then as we're listening to the patient's chest, we can listen to the lungs as well. Okay, and what are we listening for in the lungs? Bivasal cavitations. Excellent. Okay. Now, is your examination finished yet? No. What else do you need to look for?
Edema.
Edema where?
Edema.
Pitting edema at the ankles? Yeah. Is pitting edema confined to the ankles? Or not?
No.
No, it's not. It can go all the way up the lower limb. So it's also important to find out, up to where it goes to. Not just that there is pitting edema peripherally. Okay? Alright. So those are the crucial things that you need to look for. Okay. Next slide. So and these are the examination findings. So the patient is alert, bilateral fine freckles up to the mid zones. Respiratory rate of 28. What do you think about that? Is it normal? A bit fast? Yeah. Okay. Pulse, heart rate of 120. What do you think? What is normal heart rate? Okay, good. And the blood pressure, what do you think about that? How high? How very high is it? Excellent. It's dangerously high. The patient could have a stroke. Do you think the patient could have a stroke? Okay. Peripheral pulses are normal, JVP is elevated, and there's a third heart sound audible, gallop rhythm, cardiomegaly. So now you've got your diagnosis, isn't it? The patient has got congestive cardiac failure and pulmonary edema, right? And so what is it that is causing the patient's breathlessness? The pulmonary edema. So it's more a cardiovascular cause rather than a respiratory cause. Okay? So before we show the next slide, I can show that one. So your provisional diagnosis is congestive cardiac failure. Right. What about the other ones that we talked about, like pneumothorax, pulmonary embolus? Is there anything else that we had on the list that we didn't cross out? Asthma, yeah. So what do you think about all those? Just leave them in the differentials and maybe come back to that if things change? Yeah. Okay, investigations. Someone out there said ECG, correct. What are you looking for in the ECG? Nothing. What are we looking for in the ECG? Changes in the ST segment, yes. ST elevation, T-wave inversion. So you're looking for signs of cardiac ischemia, isn't it? Or myocardial infarction. Okay. What are the investigations? Echo. Alright, let me share something with you. What is the most common time of the day that a 53-year-old woman would develop congestive cardiac failure?
Early morning.
At what time in the morning? 5 in the morning. Okay. So how easy is it to get a cardiac echo at 5 in the morning? That's right, because you get shouted at first, isn't it? For waking up the cardiologist. So before we go on to the cardiac echo, what else can we do that's easily accessible? Chest X-ray. That's right. And what do we hope to see on the chest X-ray? Cardiomegaly and the signs of pulmonary edema. Right? Okay. What other tests do you want to do? That's right, you want to stick a needle in to get some blood. So you're looking for cardiac enzymes. Yeah? What else? Cholesterol? Yeah? But will cholesterol change your management in the acute situation? No. What else do you want to test for in the acute situation that will help you with the patient's management? ABGs? Yeah? Excellent. Yeah? Electrolytes? Yeah? Why? Very good. So thinking like an example now. Looking at the cause of hypertension. Now, that is right. You need to know the sodium and the potassium, right? Any other reasons why you need to know the sodium and the potassium? So, it can cause arrhythmias. Yeah, that's right. And in patient with, now we're getting further on a bit now, and this is, I suppose this is, I guess you're looking at more complications of the case now. So looking further, what we call thinking laterally. So you've got the diagnosis, you're thinking about other conditions that could be associated with this. So you're talking about causes of hypertension, yeah. And you're talking about things that can cause arrhythmia, like electrolyte imbalance. Yes, that's correct. What can cause electrolyte imbalance in this patient? Wait, 20 years of hypertension? Yeah. Yeah. So renal failure, chronic renal failure can do that. Yeah. Okay. Are there any other investigations you want to order? What profile? Renal profile like what? Because if you just write down renal profile, on the form will just come back to you with a big question mark. What? Sorry? We're going to talk about electrolytes. Anything else? Yeah, creatinine, yeah, which is usually comes with part of the electrolytes. Yes, yeah, all that comes with the electrolytes. Any other simple blood tests that you might want to know?
Sugar.
Sorry?
Sugar level.
Blood sugar level? Yeah. Okay, what else? That is important. Often we forget about that, but yeah, that's important. What else? Kidney clearance. So we're looking at renal function now. Yeah, but then in the acute situation, you probably won't want to worry about that just yet because this patient is gradually dying because she can't breathe. Blood count? Do you think it's worth checking the HP? Yes, it is. Okay, so now let's try. I don't have any sort of slides for this, but now that we've established that the patient's got acute pulmonary edema, right, and we've got and say it was caused by an acute myocardial infarct, which commonly occurs between 4, 5, 6 a.m. Right? What do you do? How do you treat this patient and how do you save this patient's life?
Diuretics.
Diuretics. So you stick a cannula in, like an IV line in, take your bloods. And what diuretic do you want to order? Someone said furosemide. That's right. Furosemide. Do you know how much to give? Okay, that's okay. I don't know either. That's why I asked. Yeah, furosemide, and that's why you need to know the potassium as well, because furosemide will cause hypokalemia. Okay. Give furosemide. How long does furosemide take to work? 6 hours. It's a bit quicker than that. Half an hour if you give it IV. So within half an hour, the patient should start to improve. And if the patient doesn't improve, what do? Give some more furosemide. Monitor the urine output. Get the nurse to put in a urinary catheter so you can monitor the urine output. Right? What else do you need to give? What do you need to give the patient who can't breathe and say, doctor, I still can't breathe. You give me all these drugs, I still can't breathe. Yes. You want to, that's right, you want to put the patient on oxygen, put an oxygen saturation monitor on so that you can monitor the oxygen saturations, and then wait for the drugs to work. Okay? And then if the patient has got an acute myocardial infarction, then you're looking at treating the myocardial infarction as well with what? Sorry? Nitrates, yeah. Okay? And I guess you know all about all that, isn't it? Because I'm a pediatrician, I don't treat people with congestive cardiac failure. Not anymore anyway. But yeah, so that's how you try and work out what the condition is, and that way you know how to treat the condition. Alright, let's look at the next case. Oh wait, actually before we do that, let's have a look at the ECG. This is the patient's ECG. Alright, can I have one volunteer to read the ECG? Someone? One volunteer, please. It's worth a Milo bar. Okay, over there. Yeah? But you get the feeling that there's tachycardia by just looking at how closely spaced the QRS complexes are, right? Okay, excellent. Yeah, correct. Yeah. Which ventricle? Because of the tall QRS complexes. Okay? Excellent. Excellent. Yeah. So we've got signs of ischemia. Do we have signs of infarction? Okay. Excellent. So we've got that's very good. So you've got left ventricular hypertrophy that would have been caused by the long history of hypertension. And then we've got signs of ischemia and also infarction in the lateral leads, isn't it? So you're thinking of somewhere in the left ventricle that's causing this, and therefore there's left ventricular failure, and therefore pulmonary edema, which then spills over to the right side of the heart and causes right heart failure, right? With a raised GDP and peripheral edema. Okay, let's have a look at the X-ray. I need another volunteer to read the X-ray, please. Anyone? Okay, up the back. Cardiomegaly.
And increase in heart in the lung picture.
So there's cardiomegaly, right? Do the lung fields look normal or abnormal? Okay, so say that lung fields are abnormal. Opacity is where?
On both sides.
Yeah. Yeah.
Lower.
In the lower lobes. Yeah. Anything else you can say about the opacities? Because if I'm just listening to you without seeing the X-ray, I'm thinking, does this patient have TB or bilateral pneumonia? Or is this patient of pulmonary edema? So how do you describe the difference between the two?
The left side diaphragm is increased.
Yeah, you're on the right track. It's obscured, you can't see it.
Maybe by because of the heart.
Because of the cardiomegaly and because of the opacities in the lower zones of the lungs, right? And then there's some patchy changes that are more prominent in the highland areas, but they're spilling out towards the peripheral areas as well. And the changes are what I think to be consistent with pulmonary edema. And that's how you can actually convey that message to another doctor on the phone. Excellent. Excellent. Okay. All right. Let's see. We can see. Okay, should I? Yeah. So that's what the condition is. Okay. All right. Let's do another case. We've got time for one more. Anyone? Okay, now we have time for one more case. Okay, now I hope you sort of